Hello dear colleagues. Today I will be discussing the problem of dyslipidemia with you, which is an extremely common clinical disorder. We all appreciate that the global mortality from cardiovascular disease is extremely high. As a matter of fact, more than 50% of deaths all over the world are due to cardiovascular disease like stroke and coronary artery disease. And the basis of this cardiovascular disease, as we know, is atheromatosis. Now, with specific reference to our country, the coronary heart disease is even commoner than what it is in many other countries. As you see here, compared to Japanese or Chinese or Americans, Indians have several-fold, many-fold coronary artery disease. And of course, there are many factors which predispose us to this coronary artery disease, of which dyslipidemia of a peculiar type, the typical Asian Indian type, is also important, which I am going to discuss with you a little later on. There is also very high incidence of coronary artery disease in young people, which is devastating because it takes away the livelihood of these people or these families so early, and therefore has disastrous social effects. Again, look at the trend of coronary artery disease mortality in India, and as you see here, from year to year, from decade to decade, like 2010 to 2020, as projected, the coronary artery disease in India is mortality due to coronary artery disease is steadily increasing, and it has not leveled off. I must point out to you that in many advanced countries there is already a trend towards blunting of this curve, and as a matter of fact some reduction in cardiovascular mortality. So, we have yet to cross this escalation of disease, followed by, of course, hopefully stabilization. Again, in South Asians, which includes Indians, you will see, look at the factors which really change our coronary artery disease, and there are factors which go against the development of coronary artery disease, of which the consumption of fruits and vegetables and moderate to high intensity exercises, you see, and less obesity, especially less truncal obesity and less hypertension. And you see that in South Asians, some of these factors are not operative, so that the incidence of coronary artery disease or mortality therefrom is high. Now, prevalence of dyslipidemia also, if you look at here in the Asians, which includes the Asian continent and includes India, Pakistan, Bangladesh and Nepal, Sri Lanka, and as you will see here, you see the dyslipidemia is common in this group of people. So, you see here all indicating in the Asians the higher incidence of dyslipidemia. Another important facet of this is, like last slide we saw, really was the cholesterol levels and LDL cholesterol levels, and how many of them have less than 100, 100 to 130 and more than 130. The next lipid that we look at is the triglycerides, and as you see here, Asian Indians versus Caucasians in this slide, you will find that again the hypertriglyceridemia is highly prevalent in Asian Indians. So, these are some of the typical dyslipidemic features which prevail in our community, which predisposes us to the coronary artery disease. Again, looking at the ethnic differences, you will see that the LDL cholesterol, HDL, triglyceride and lipoprotein A, which are the four lipids we consider, of which primary of course is LDL cholesterol, but you also know that low HDL as well as elevated triglycerides and high lipoprotein little a also are important atherogenic particles. So, you can see, compare the Asian Indians with different communities like the Afro-Americans or Chinese or Japanese, and you will find we have several problems. Besides low HDL, we have high LDL cholesterol, we have very high triglycerides, is very common in Asian Indians, and lipoprotein little a, which is partly the inherited anomaly, is also highly prevalent in our community. Now, what are the factors which predispose to elevated triglycerides? We know that elevated LDL cholesterol is an inherited abnormality, usually due to what we call combined combined hyperlipoproteinemia, which is very prevalent in our community. But the triglyceride elevation can also be secondary to many diseases. And when you are trying to address this issue, you are going to treat the primary disease, which will result in the effective lowering of triglycerides. High triglycerides can be due to some primary diseases like obesity, physical inactivity, tobacco abuse in the form of cigarette smoking or chewing tobacco, excessive alcohol intake, and a high carbohydrate diet. In our country, the carbohydrates constitute almost about 60-65% of calories, which you know is a very high carbohydrate composition. And of course, there are three common diseases which are associated with very high triglycerides. One is type 2 diabetes, rampant in our country. Renal failure produces a very bad atherogenic lipid profile, and of course triglycerides are very high there. And we know that hypothyroidism, even of the mildest degree, causes a raised triglycerides and to some extent also raised LDL cholesterol. Certain drugs, for example, oral contraceptives, can raise triglycerides to a remarkable degree in some individuals, in rare ones, but the rise can be so phenomenal that it can even, I've seen even acute pancreatitis occurring because of elevated triglycerides. Now, of course, we know that triglycerides also, like LDL cholesterol, be inherited. So, when we look at high triglycerides, we should think of the primary causes and see if they can be eliminated in order to get good results. Is triglyceride level, high triglyceride level, an independent cardiovascular risk factor? This has been debated all along. However, there are many studies which are quoted here on this slide, like ProChem, Copenhagen, Mail Study, Lipid Research, Clinics Follow-up, Helsinki Heart, Framingham Heart Study, the most famous one. All of them have pointed some importance of triglycerides. Some of them have postulated that isolated triglyceride rise may not be as atherogenic, but when it is accompanied by elevated LDL cholesterol or lower HDL cholesterol, it assumes great significance. And unfortunately, in clinical situation, quite often all these abnormalities run together, and in that context, I think triglycerides do become important clinically. The metabolic syndrome, with which you are quite familiar, you know that in India almost 20-25% of people suffer from metabolic syndrome, an extremely high incidence, which you know it consists of obesity, especially truncal obesity, insulin resistance, hyperinsulinemia, and a host of other abnormalities described there. And dyslipidemia is also one of those abnormalities. And of course, the primary problem in the metabolic syndrome is high triglycerides, and of course very high postprandial lipemia. I must tell you that we haven't been looking at postprandial lipemia as closely as yet, but a lot of data are emerging showing that we should be really studying as we go along postprandial high triglycerides. And of course, the low HDL cholesterol is also typical of metabolic syndrome. In diabetes, dyslipidemia is extremely common. As you will see here, the percent of people, both male and female, will have elevated triglycerides or elevated LDL cholesterol, you see, and of course, you can see the prevalence is extremely high, especially low HDL cholesterol is to the extent of 70-80%, and the high LDL cholesterol, you see, is close to about 40-50%. So you can see the extremely rampant abnormalities of lipids, especially in uncontrolled diabetes. This is some of our own data published long ago showing that, you see, compared to non-diabetics, of course, newly diagnosed diabetics have significantly abnormal lipids like elevated cholesterol and triglycerides. However, a very important clinical finding here is that if you control diabetes very well, you see, then the number of people with lipid problems slowly get less and less. For example, triglycerides, which were initially abnormal in 25 out of 55, in the end of 9 months, there are only 10 out of that who have persistent triglyceride abnormality, and so also the cholesterol also drops with the control of diabetes. This is very important, so that if you wish to correct dyslipidemia in a diabetic, you should also ensure that prior to that the diabetes has been reasonably well controlled for the past about 6 to 8 weeks, and thereafter you draw your conclusions regarding whether you should institute drug therapy or not. Low HDL cholesterol is a worldwide frequent abnormality. As a matter of fact, unfortunately, we don't yet have, very good strategy to increase HDL cholesterol, but we must know that it's a very common abnormality, and of course in India it is far commoner, and with the metabolic syndrome again, very characteristically the HDL cholesterol is low. We know that high density lipoprotein has the property of anti-atherogenic effects, and it does it by multiple pathways. For example, it is responsible for reverse cholesterol transport, as we know very well, and of course it also has antioxidant, anti-inflammatory and anti-thrombotic and vasoprotective effects. So HDL is an extremely important lipoprotein preventing atherogenesis. And the lower the level of HDL, as you see here, higher is the coronary artery disease. As you see here, the very low, like less than 25, the coronary artery incidence is extremely high. Another abnormality which also we are nowadays considering is small dense LDL cholesterol, because it is highly atherogenic. It is the one which is very likely to get oxidized, and also it increases vascular permeability and does a lot of other things with like decreased affinity for LDL receptor, so that overall it is very atherogenic. It is an inherited phenomenon, and it is not as modifiable as the other lipid fractions. Remember that as the lipid fraction becomes smaller and smaller, they are more atherogenic. So the particle size is very important. So the small dense particle, LDL particle, is highly atherogenic compared to any other lipids. So in a way, it is number of particles that are present in the blood are important. So the smaller one, the number is more, and therefore atherogenicity is enhanced. Now, how do we diagnose hyperlipoproteinemia or dyslipidemia? And the older classification, which to some extent is even important today, or diagnostic criteria, is that LDL cholesterol optimum is less than 100, and somebody having cardiovascular disease, it has to be in the optimum level, or even as low as 70 is the target, while of course the borderline high is 100 to 129, and above 139 is above 130 is high, and above 160 extremely high, and definitely requires drug therapy. Remember that lifestyle modification do not modify the LDL cholesterol as effectively as they modify triglycerides, and therefore it may be important for you to consider drug therapy if you find that LDL cholesterol is very high, especially in the high or very high range. Total cholesterol criteria are different one. They have become important again because nowadays, while determining the need for statin therapy or hypolipidemic therapy, we utilize a set of new criteria which were described about 3 to 4 years ago in a study called Atherosclerosis Cardiovascular Disease Program, and there again the total cholesterol has been considered, because the authors of this article felt that the massive data that are available are on total cholesterol and really not on LDL cholesterol, and therefore they went back to the criterion of total cholesterol being high. HDL being low, especially less than 40, is very bad, and of course male and female there is slight difference. In female you expect it to be minimum 50, in males minimum 40. So below that it is low HDL cholesterol. The atherosclerotic cardiovascular disease, the risk categories are very important, and this is what is described recently by that ASCV the criteria. And remember that you see very high risk category, as you will see here, is really pre-existing cardiovascular disease itself. So somebody who had already had a myocardial infarction has a very high risk, and of course there are many other reasons for high risk category, like there is a familial homozygous or heterozygous hypercholesterolemia, there the rise of cholesterol is very high. So, these are extremely high risk category, the very high risk category. Then the high risk category is very common. Again there of course more than 3 ASCVD risk factors are important, and not necessarily an event, cardiovascular event, but 3 risk factors or more are important. And of course chronic kidney disease falls there, and if there is genetic background, again it is very important. Now remember that in these 2 categories, one really thinks of instituting what is called high intensity statin therapy. See, now the statin therapies are not oriented towards what should be the lowering of LDL cholesterol or total cholesterol. They are oriented more towards high doses, that is intensive therapy, or moderate dosage or low doses. And of course, invariably they do lower the LDL cholesterol quite well, but some of us who are still used to looking at the older criteria will still see whether LDL cholesterol has come to less than 70. By using some of these approaches recommended by ASCVD risk categories, frankly the LDL cholesterol does drop quite well below 70, sometimes as low as 50, which is quite all right. And of course, there are low risk categories as well. Now, when we think of high, moderate and low intensity statin therapy as recommended in ASCVD criteria, then the doses are as listed here. Like atorvastatin, the high intensity is like 40 or 80 milligram, rosuvastatin 20 or 40 milligram. The common mistake which is prevalent in our country is the use of lower doses of statins. Not rational. As a matter of fact, if a patient tolerates a small dose like 10 milligram of rosuvastatin, same person will tolerate 20 or 40 milligram as well. So, there is no reason for us to use those lower doses, which we are doing quite commonly. So, I think we should use adequate doses, and where high intensity is required, you must see here that doses are much higher than what most of us are used to in the clinical practice. So, the treatment goals. So, once you start, what are the treatment goals? You see, as I told you, according to ASCVD criteria, you institute statin in the properly recommended doses like high intensity, moderate or low intensity, and you truly don't check how much LDL cholesterol has been lowered. However, most of us mentally are also tuned to old JNC criteria, and there you know that the LDL cholesterol targets were described, and if you see that, you will find that in very high risk, the higher the risk you like to lower the LDL cholesterol further. So, you can like to go to as low as 50, and in high risk less than 70, and if moderate or low risk less than 100 is fine. And so also regarding the non-HDL cholesterol, I must tell you that besides LDL cholesterol, our next target currently recommended is non-HDL cholesterol. So, non-HDL cholesterol is usually about 30 milligram higher than the LDL cholesterol. So, when you say 50 for LDL cholesterol on this slide, it is 80 milligram for the non-HDL cholesterol. So, I think you should consider drug therapy whenever things are not in order, and as a matter of fact, statins have been most widely used drugs, although a lot of side effects and things are described in the lay literature, but I think we have to convince our patients that the drugs are very safe, and as a matter of fact, they may be one of the single most important group which has resulted into prevention of coronary artery disease, and in fact adding longevity all over the world. So, I think people have to understand this in spite of very odd thing described on the internet by lay people. How low should you go on LDL? There is a debate, but the fact is that lower you are, better you are. So, you try to go as low as possible. Certainly, most cases below 70 when there is already a pre-existing cardiovascular disease, and maybe at least 60, or even you can go as low as 30. Some of the physicians who are not used to looking at such low values get alarmed, and quite often they withdraw statins or they de-escalate the dose, but it is not very rational to do that. Non-pharmacological therapies are always considered, and they may be important not necessarily from clearing the lipid problem, but they do give you a lot of other cardiovascular benefits, so like aerobic exercise. And remember, one very important thing is tobacco cessation. You see, and we know that there are not many strategies to increase HDL cholesterol, but tobacco cessation is one strategy and weight loss is another strategy which will increase the HDL cholesterol, which is otherwise considered extremely difficult to be done even by the pharmacological means. Alcohol consumption in a large amount, then of course the curtailing alcohol intake will definitely lower the triglycerides very effectively. So non-pharmacological therapy should always be considered before starting the drug therapy for the regions. They do give you multiple benefits in many different areas of lipids and not necessarily one lipid group, and of course they also improve many other cardiovascular risk factors. So we should never lose sight of these important modes of treatment. Statin is the gold standard of therapy for lipids, you see, and you see numerous studies, very primary prevention trials, secondary prevention trials, where the use of statins definitely reduced the coronary artery disease to different percentages in different studies, but anywhere from 30 to 50% benefit can be expected regarding the atherosclerosis or cardiovascular disease. So some of these trials I will pass off very rapidly, but I must tell you that the massive evidence that these drugs help, including the Jupiter trial, you see, which was in diabetics. So in diabetics, again, some of these studies have included a good number of diabetics in the study, and there again the benefits have been shown. So cardiovascular events are reduced by statins. So we can pass on some of these, the massive data, but I think just to give you the importance of this, I have these slides here, but remember that all these studies have shown distinct benefits. So any of those who still have questions about statins really should remove this misconception from their mind. See, so similar things shown in all the studies, and you can see that statin favors the cardiovascular protection as compared to the control group in most of the studies, and reduces the hazard ratio from anywhere from 0.3 to even maybe 0.5 or 0.6. So again the same data shown all of this, so I am going to pass off rapidly for want of time, but important thing is to know that statins are very effective drugs in lowering the lipids, especially LDL cholesterol, which definitely has impact in improving the cardiovascular outcomes. Do the statins reduce triglycerides? If there is mildly raised triglycerides, remember that statins may also address that issue. Although severely raised triglycerides require a different therapy, and you can see here some of the lovastatin, pravastatin, and simvastatin, to some extent lowering the triglycerides as well. Otherwise, probably very high triglycerides, if they persist after control of diabetes and weight control, thereafter it persists, then you may require to use the second very important anti-lipidemic therapy, and that is the use of fenofibrate or fibric acid derivatives. There are some of the other drugs, the fibrates I must emphasize are a very important tool available to us for lowering lipids, especially of course the triglycerides. Fibrates also have a property of slightly increased HDL cholesterol, which is a very welcome change. Niacin has had its role in many areas, but it is nowadays used only in very difficult lipid problems where you are not able to get optimal results with the use of statins or fenofibrate, then you can consider niacin. However, I think if you can master the use of two drugs, that is statins and fibrates, I think you will be able to address the issue of hyperlipidemia in most of your patients. This is a ADA, American Diabetes Association and American College of Cardiologists joint consensus statement, and it again tells you that high risk patient, known cardiovascular disease, diabetes itself is considered high risk even in the ASCVD criteria, and there is additional risk factors, then your target should be stricter, and you see highest risk and high risk are different, and again moderate risk is different. So this we have seen and most of us approach it from two angles, that is criteria proposed by ASCVD study and criteria which earlier existed in JNC studies. Remember that we are now looking beyond LDL cholesterol in order to address the issue of the remaining cardiovascular mortalities, which continues to be high in spite of use of statin therapy. And there again we are now looking at, as we discussed earlier, the non-HDL cholesterol levels and low HDL. So So, I think these two are another important targets to look at, and I think if we address all these beyond LDL cholesterol, we probably get the best cardiovascular outcomes in our patients. So, let me summarize by saying that hyperlipidemia, especially high LDL cholesterol, is a significant cardiovascular risk factor. We Indians also have high triglycerides and low HDL cholesterol. The cardiovascular risk should be assessed by atherosclerotic cardiovascular disease criteria, and primarily LDL cholesterol should be targeted by statin therapy depending upon what is shown in this program, either by low, moderate or high statin doses. Remember that besides high LDL cholesterol, high non-HDL cholesterol and low HDL cholesterol also should be targeted.